All right, thank you. We're going to go into the scientific session. Dr. Yip, Lynn Yip.
Dr. Caitlin Yeo, and we're going to introduce Dr. Dhruv Patel, presenting Are the Robots Taking Over? Changes in Operative Approach for Adrenocortical Carcinoma in the U.S.
Good afternoon. My co-authors and I would like to thank the association for the opportunity to present our work. We report the following disclosures, none of which are related to the methods and findings presented. The technical advantages and perioperative benefits of robotic surgery have expanded its utilization for benign indications for adrenalectomy, yet consensus guidelines recommend an open resection for adrenocortical carcinoma, ACC, as the oncologic standard. It remains unclear whether surgeons at the national level are expanding the boundaries of robotic adrenalectomy for malignant disease. The aims of our study were to examine national trends in utilization of robotic adrenalectomy for ACC, to identify factors associated with the robotic approach, and to assess the oncologic safety of the robotic approach with respect to margin status and survival. We reviewed the National Cancer Database between 2010 and 2022. We included patients with ACC who underwent adrenalectomy with known operative approach. We performed a stratified multivariable analysis fitting separate models to identify factors associated with robotic adrenalectomy relative to an open operation and robotic adrenalectomy relative to laparoscopic surgery. To account for the clustering of patients at the facility level, cluster robust standard errors were reported. And we examined overall survival estimates by approach using the log-ring test and a Cox regression analysis to identify adjusted factors associated with survival. 2,481 patients met inclusion, among which 65% underwent an open adrenalectomy, 22% laparoscopic, and 12% robotic. Here we present a percentage breakdown of cases performed by approach per year. There was a proportion, with the blue bar representing the proportion of cases performed robotic. There was a proportional increase in robotic adrenalectomy from 4.5% of all resections in 2010 to 20.7% of all resections in 2022. Our multivariable model for factors associated with robotic adrenalectomy relative to an open resection was adjusted for the factors listed below. Compared to patients who underwent an operation before 2018, patients who underwent surgery in 2018 and after had an adjusted higher likelihood of receiving a robotic adrenalectomy. Increasing tumor size between 5 and 10 centimeters and greater than 10 centimeters was associated with a lower likelihood of receiving a robotic operation compared to tumors that were 5 centimeters or less in size. Positive resection margins and unplanned readmission were not associated with operative approach. Our multivariable model for factors associated with robotic adrenalectomy relative to laparoscopic surgery was again adjusted for the same variables listed below. For patients who underwent surgery before 2018, patients who underwent an operation in 2018 and after again had an adjusted higher likelihood of receiving a robotic adrenalectomy. Tumor size, resection margins, and readmission were not associated with operative approach. Here we present unadjusted survival estimates by operative approach. 5-year survival estimates for a robotic adrenalectomy for ACC was 55%, for laparoscopic 51%, and for open adrenalectomy 48%. There was no statistically significant difference in survival by approach. Our Cox regression model for survival was adjusted for the factors listed below. For patients who underwent a laparoscopic or robotic adrenalectomy, there was not an adjusted increase or decrease in the likelihood of long-term mortality compared to an open adrenalectomy. Clinical stage 4 disease and positive resection margins were associated with a higher likelihood of long-term mortality, and receipt of adjuvant therapy was not associated with survival. Our analysis is limited by inherent selection bias and omitted variable bias resulting from retrospective design. We are unable to evaluate select oncologic outcomes for significance, including tumor rupture, local recurrence, peritoneal carcinomatosis, and recurrence-free survival. We are also unable to determine surgeon intention to treat and preoperative diagnosis of ACC. Still, we report a well-powered contemporary analysis at the national level that has demonstrated robotic adrenalectomy for ACC has increased relative to open and laparoscopic approaches over the past decade with no compromise in oncologic outcomes. Time and tumor size appear to be driving adoption of the robotic platform. Clinical practice in the operative management of ACC appears to be changing despite guidelines recommending open resection. This concludes my presentation. Thank you.
And we've got Quan Du over here.
I have a question for you. When we operate on adrenal tumors, frequently we would do it because we think it may be cancer. We don't know for sure. So can you tell me under what circumstances you would not do a laparoscopic or robotic? I assume you probably use similar criteria for both. Are there situations, because if you look at a paper like this, I can do whatever I want, and they all do the same, right? So are there situations that you would not do either a laparoscopic or robotic operation?
Yes, thank you for the question. I think in a situation where there is a local invasion that would require a multivisceral resection, that would be an instance where I would not consider doing using a minimally invasive approach for resection. And again, due to limitations in the database, we're not quite able to ascertain how many patients had multivisceral involvement. And again, there's a variable for tumor thrombus, but again, very poorly captured with a large degree of missingness. But that would be perhaps another instance where I would have a little pause in employing a minimally invasive platform.
Just a quick reminder to also state any conflicts of interest, please.
Phoebe Zhang, Baylor College of Medicine. I also work for Intuitive Surgical. I had a question about whether this database has any information regarding conversions, because like Dr. Ju said, a lot of times we go in there and we don't know for sure if it's going to be ACC or not, and sometimes the decision-making changes intraoperatively.
Yes, there were 110 cases among the 2,481 that we presented that involved conversion. 87 of those were from laparoscopic to open and 23 from robotic to open, which is about 15.7% rate of conversion in the laparoscopic cohort and 7.5% of rate of conversion in the robotic cohort. That difference was statistically significant. We did perform a sensitivity analysis where we excluded converted cases, and the results remain the same.
Thank you. We have Dr. Berber, I think, over there.
Aaron Berber, Cleveland, Ohio. I congratulate you for your study. Obviously, not knowing the indications for surgery and whether the surgeons really suspected the adrenocortical carcinoma or not is the major weakness of your study. That you have emphasized that, like, more than the technique, the most important factor is the surgeon's kind of the surgical kind of experience. I wonder if you had data in this database about including surgeon experience and whether that was a major factor in outcomes.
Yeah, unfortunately, due to limitations in the database, we do not have a variable that would allow us to ascertain surgeon case volume, but that would be an interesting direction to perhaps further evaluate the findings and results that were presented.
Yeah, we have time for one more question. Maybe we'll come to the far right here.
Yeah, thanks. Matt Nays, Boston, no disclosures. So what do you mean by open? So did you clarify, like, what open technique did you use? Because are you using midline, modified Mikuchi, subcostal, thoraco? They're all different. A lot of these big ACCs are fibrotic. They're stuck in the retroperitoneum, and they're really hard to mobilize, even with a huge open incision. And so when you're trying to mobilize this thing and you don't have the right exposure, you increase the risk of fracturing it. So if you have, let's say, a heavy person with a midline exposure, you might not be able to see so well compared to a Mikuchi or a subcostal or a thoraco. So did you clarify, can you clarify what open techniques were used here?
Yeah, the specific operative approach and the incision type would be of interest, especially in an operation like an adrenalectomy. Unfortunately, the National Cancer Database does not abstract data to that level of granularity, where we could say, you know, it was this specific open operation or open approach that was utilized?
Yeah, I mean, I think it's extremely important because in the end, the patient wants, number one thing is to have the entirety of the tumor out and not fragmented. Sometimes the visualization actually might be better with a laparoscopic approach, or actually might be better with a robot, but actually removing it whole and intact is the number one objective. So that might be helpful. Thanks.
Thank you. I think we're done for time.
Next presentation is use of adrenal vein sampling in patients with hypercortisolism. When is their clinical value? Presented by Dr. Pan and her colleagues at NYU.
Hello, everyone. Thank you for the warm introduction. Actually, not yet a doctor. I'm a fourth-year medical student at NYU, and it's an honor to present at AES. The contents of this presentation represent further work performed since the submission of the abstract. The overall message and substance of the results remain the same. These are our disclosures. Adrenal venous sampling is routinely used in primary aldosteronism, but its role in ACTH-independent hypercortisolism remains unclear, and particularly in cases of bilateral nodules, there remains a need to determine the optimal operative strategy. In these cases, we aim to reduce the incorrect side adrenalectomy or need for unnecessary total steroid replacement. And so we ask the question, what is the clinical utility of AVS in these cases of ACTH-independent hypercortisolism? Our methods were twofold. The first part was a retrospective case series, and the second part was a scoping review. And we completed a case series of all patients who underwent AVS at our institution with biochemical evidence of hypercortisolism as defined by a DST cortisol greater than 1.8 or a urinary free cortisol greater than 45. We ultimately excluded co-secreting nodules. The flowchart on the right shows that we ended up excluding 8 patients with co-secreting nodules. We utilized an AVS lateralization index of the dominant-sided cortisol over aldosterone over the non-dominant-sided cortisol over aldosterone with a ratio greater than 2 indicating lateralization. Clinical and biochemical outcomes were categorized as improved, partially improved, or persistent. The second part of our study was a scoping review, which we ultimately elected to complete due to our small sample size and the limited existing comprehensive analysis of this topic. And we included studies with 5 or greater patients and excluded those with cholecystecreting aldosterone tumors or those that did not delineate treatment outcomes. Results of the retrospective case study: 9 patients were included, 8 of whom were female, median age 60 years, 7 presented with MACs and 2 with symptoms of overt Cushing's syndrome, 6 had bilateral nodules, and the mean adrenal nodule size was 2.71 centimeters. AVS lateralization corresponded to the site of the larger unilateral nodule in 5 patients, was non-lateralizing in 3, and in 1, AVS lateralized to the smaller nodule. And it's a busy table, but this table summarizes the results of our cohort grouped by those with concordant AVS results, non-lateralizing results, and this patient where AVS guided clinical management. So we'll focus on that patient who was originally presenting with overt Cushing's syndrome with physical features. DST cortisol at presentation was 5.8, and urinary free cortisol was 49.5. Imaging showed bilateral, similarly sized adrenal nodules. AVS lateralized to the left side with an index of 4.7, ultimately leading to that patient undergoing a left adrenalectomy. Patient post-op required 2 months of steroid replacement and experienced resolution of those overt Cushing symptoms. At 2 years, experienced a recurrence of weight gain without other Cushingoid features, and DST cortisol at that time was 3.1, consistent with the diagnosis of MACs. For a scoping review, 9 studies were included, ranging from 6 to 39 patients, and we looked at various themes, including the use of different lateralization indices, the use of dexamethasone suppression during AVS, but in this presentation, I'll just focus on discussion of size-function discordance. Euland et al. Demonstrated that 9 of 20 patients with unilateral tumors had bilateral cortisol production on AVS, and conversely, 4 out of 14 with bilateral tumors had unilateral production on AVS. And Achari et al. Demonstrated that 50% of patients with bilateral nodules demonstrated discordance between the larger lesion and the higher adrenal vein to peripheral vein cortisol ratio. And so in conclusion, AVS may play an important role in select cases with bilateral similarly sized adrenal nodules, especially in these cases where reliance on imaging alone risks incorrect side adrenalectomy or unnecessarily bilateral adrenalectomy. We propose a best practice approach based on the case study and scoping review, which includes consideration of AVS in cases with bilateral nodules differing by less than ½ centimeter in maximal diameter, that AVS be performed with dexamethasone suppression, and that multiple reference hormones be collected during the process of AVS, including aldosterone and metanephrines, to facilitate the calculation of various lateralization indices. Of course, we recognize the considerable limitations of having such a small sample size and incomplete postoperative follow-up, yet we hope that this provides some increased additional information on the use of AVS. Thank you very much, and thank you very much to my mentors.
Nice work, nicely presented. Dr. Sada.
Ala Sada, University of Pittsburgh. Great study, and it's very interesting topics. Did you include, where this patient has just isolated bilateral adenoma, or did you have any patient with primary bilateral macronodular adrenal hyperplasia?
We had patients with both ultimately on final pathology.
Because interesting, like if you have like a preoperative CT scan, because we have to make this decision, before surgery. I think for BIMA, we like primary bilateral macronodular hyperplasia, we know it's a bilateral disease, but I'm interested more in isolated bilateral adenoma, because I think this is the situation where IVS will be most helpful. So I think in the manuscript, it would be better to differentiate between the two groups.
Certainly. Thank you for your comment.
Hi, thank you. Lila Morris-Wiseman, Johns Hopkins. Very nice study and very well presented. I'm curious, and maybe it was on your table that I couldn't see, but whether you had biochemical outcomes for the remainder of patients. You presented one patient that was positively impacted temporally by the AVS results, but what were your other biochemical results?
Yes, I have an additional slide on that. Thank you for that question. Whoops. Okay. Since we had categorized by improved, partially improved, or persistent, that was based on repeat DST cortisol if available, whether it was normalized or whether it was decreased from prior, yet not completely normalized, as was the case in that patient that we singled out. Here's the overall summary of clinical outcomes and biochemical outcomes for all 7 patients that ultimately were surgically treated. Unfortunately, due to historical changes in practice patterns and inconsistent availability of this data, some patients do not have repeat biochemical testing.
Thank you. Fiamma Warieko, Salt Lake City, no disclosures. Congratulations on your paper, it's well presented. Quick question about the, if you had just taken from your retrospective data, taken out the larger lesion, how would the outcomes be different compared to what you did with the concordant or discordant study? Because your scoping review showed that it's really half and half. If I saw that people would get better. Then the second question is really how durable was the response that you got in the patients who you had some improvement after unilateral adrenalectomy? But I think it was well presented. I think it's actually doing a multi-institutional study around this would really help us understand this better, but really well done. Thank you.
Thank you for your question. Just to summarize, the first was about if simply the larger lesion had been removed, and the second was about durable response. The first question I think is a little harder to answer because typically the clinical choice is to remove the larger lesion, and simply because the lesions were so similar in size, essentially the same size, because of that, the AVS was ultimately helpful. and agreed that the durable response is an interesting question because is it really worthwhile to have X number of years of life without steroid replacement if a patient is ultimately going to need a completion adrenalectomy? I think that in this patient, it was worthwhile for quality of life to be living with MAX without steroid replacement, but certainly we also acknowledge the limitations of proceeding in a stepwise fashion.
Last question, Dr. Berber.
Congratulations for your study. I just one question, maybe I missed the detail. Looked like 6 out of 9 patients had bilateral disease. Then that mean like 3 patients had unilateral disease. And why would you do an AVS?
We did have 3 patients with unilateral nodules who did get AVS. I would explain that as changes in historical practice with individual clinicians practicing based on their own judgment. And in the past 10 years, where AVS guidelines have not been clear, oftentimes patients received AVS with only unilateral nodules.
Thank you.
Thank you.
Nice work, thank you.
Thank you very much.
I'd like to introduce the next paper. So it's catecholamine-induced metabolic dysfunction in pheochromocytoma paraganglioma patients and its reversal after curative surgery, results from a prospective PheoMet study by Dr. Mithlesh Wenchu from the Sanjay Gandhi Postgraduate Institute of Medical Sciences.
Good afternoon, everyone. So it's a privilege, and I'm grateful to the AES for providing me the opportunity to present our work, the PheoMet study. And I bring greetings from SGPJMS Lucknow. It's a tertiary care institute in India, and I have no disclosures. Pheochromocytoma paraganglioma is traditionally viewed as a disease with hemodynamic abnormalities, but its metabolic impact is under-recognized and poorly quantified. And the reversibility after surgery, it's not well established. Catecholamine excess, it disrupts the glucose and fat metabolism through multiple effects of liver, pancreas, as well as skeletal muscle and adipose tissues. We aim to study these effects of catecholamine excess in our patients and also assess the reversibility after curative surgery. PheoMet is a prospective study that was undertaken from 2020 to 2025. All biochemically confirmed pheochromocytoma or functioning paraganglioma patients who provided the written informed consent were included in our study, while patients who refused the consent, non-functioning paragangliomas, and comorbid conditions were excluded from the study. 40 biochemically proven pheochromocytoma paraganglioma patients and 20 non-functioning adrenal controls were taken. Routine pre-op sampling was done in both the groups, followed by a sampling 7 to 10 days after curative surgery, and thereafter 6 months in case of patients. Glucose, HbA1c, insulin, C-peptide, free fatty acids, and lipid profile were measured, and various clinical derived indices, those were also calculated from those. Coming to the results, both the groups were age and sex matched. Pheochromocytoma paraganglioma patients had a higher BP as expected and metanephrine levels, and controls did show a significantly high BMI. On baseline comparison of glucose tolerance test curves, we can see no significant difference in glucose curves between both the groups. Insulin level showed a significant flattening of the curve in patients, and that we can see in this chart at 60 and 90 minutes. And the C-peptide levels, they followed the insulin trend and were also significantly flattened. Lipid profile demonstrated a lower triglycerides, LDL, cholesterol levels consistent with the hypercatabolic state. Among the derived indices, we can see there is an increase in disposition index compared to the controls, which reflect augmented beta cell compensatory response to the catecholamine-driven glucose dysregulation. the total insulin as well as C-peptide secretory output was significantly suppressed, and the rest of the parameters were not significant. Coming to the longitudinal follow-up of the patient, there is a significant fall in glucose level across all the time points of glucose tolerance test, which is sustained even at 6 months post-surgery. However, there is no change in C-peptide as well as insulin levels. They are signifying that there is a better control with the same insulin levels. Glucose patterns are monophasic and are preserved, and lipid profile didn't exhibit any statistically significant longitudinal changes. In derived indices, change in the disposition index as well as total glucose exposure was significant and sustained, suggestive of release of functional brake by the surgery. Total insulin and C-peptide secretory output was stable, which implied recovery of efficiency but not secretory volumes. Coming to the conclusion, pheochromocytoma paraganglioma, these exhibit a reversible metabolic alterations. The beta cell suppression is evidenced by blunted insulin and C-peptide response. Surgical cure rapidly and sustainably normalizes the glucose tolerance, which is even maintained at 6 months. Disposition index improves significantly, and it is suggestive of functional improvement in beta cell compensatory capacity. Thank you, and I am grateful for my mentors, and I'm really pleased to answer your questions.
I think we've got one at the far right.
Hi, Naresh Nilabo, NIH, and I have no disclosure. Excellent talk, and I'd like to congratulate you on a prospective study like this. My question to you is whether your cohort had patients who have norepinephrine predominant only. I think there's a difference between methanephrine predominant tumors and non-methanephrine predominant tumors in terms of metabolic response.
Thank you for your question. We did subgroup analysis. I did have the same thought, and most of the patients were norepinephrine dominant, but there were mixed patients with metanephrine levels also in our cohort. So approximately 30% of the patients were, 20 to 30% were mixed.
Thank you. I actually have a question. So I know your study mostly looked at patients with no baseline diabetes, but for example, I see often patients with pheo and paraganglioma come in with sort of mild elevations in A1C that have been started on oral antihyperglycemics. Do you guys have any sort of management recommendations or policies for what to do with those patients post-operatively? In our study, we did find that post-operatively, when we studied the data, there were multiple times, you can say 7 to 8 times, the patient did had hypoglycemia. Approximately, it went down below 50. So in case they were on oral antihypoglycemics, then they probably would require tapering, or maybe give it a day or two, check the glucose levels, and then further taper down. This. Thank you.
I had a similar question. Did you also see changes in medication use after surgery that correlated to some of these?
We didn't have any diabetic patients, so we didn't see those changes. But yeah, coming to the antihypertensive, obviously they change.
Thank you.
Thank you. Our next study is from Dr. Corman. Hopefully she's a doctor. Okay, great. Dr. Corman from NYU, titled Cardiometabolic Improvements After Adrenalectomy for Mild Autonomous Cortisol Secretion.
Hi, everyone. My name is Alexis Corman. I'm one of the general surgery residents. I'm the current research resident at NYU. It's an honor to present our findings today. These are the disclosures for our group. So first, a little background on mild autonomous cortisol secretion. It's elevated cortisol levels, but it lacks those overt clinical Cushingoid features. It's associated with increased cardiometabolic morbidity, But the optimal management, meaning adrenalectomy, compared with non-operative management of the hypercortisolism and its comorbidities, remains controversial. The existing studies have found mixed benefits across the different cardiometabolic domains following adrenalectomy, and some of these studies have been limited by things like small sample size, heterogeneous definitions of MACs, and non-standardized outcome measurements, which is what our group wanted to evaluate. So we looked at cardiometabolic outcomes following specifically successful adrenalectomy, which we defined with a biochemical resolution of hypercortisolism. We compared this to non-operative patients, and we did this using standardized biochemical definitions of MACs, standardized outcome measurements in the largest cohort study to date. We used the EPIC Cosmos database for our retrospective cohort study, which has data from over 300 million patients. We biochemically defined MACs using a DST cortisol level between 1.8 and 10, divided our cohorts up into adrenalectomy and non-operative management, and required our adrenalectomy patients to have either supportive ACTH or dexamethasone levels, since surgery itself was a good marker of an adrenal source of hypercortisolism. For our non-operative patients, unfortunately in Cosmos, you can't see imaging results, so we required this group to have both supportive ACTH and dexamethasone levels to increase the likelihood of an adrenal source. We started with a little over 19,000 patients who had ever had a DST cortisol level, applied a series of exclusion criteria, the key ones being cortisol outside our specified range, lack of those supportive biochemical labs, concurrent pheochromocytoma or hyperaldosteronism, and then lack of biochemical resolution of hypercortisolism in the surgical patients, which we defined using a postoperative DST cortisol level. We ended up with 395 patients total in our study, with 54 surgical patients and 341 non-operative patients. We did a series of analyses using inverse probability of treatment weighting. Our primary analysis was a weighted logistic regression, which looked at categorical improvement at last follow-up within a 3-year period. We did make a conservative assumption here that no follow-up equated to no improvement. We then did a secondary time to event analysis, as well as a sensitivity analysis that repeated our primary analysis using complete cases only, just to test the robustness of our results once we got rid of that primary assumption. We looked at A1C, body mass index, total cholesterol, LDL, HDL, and blood pressure. This is just a select sampling of our many baseline characteristics. The important two on this slide are the bottom 2 rows. Cortisol levels were slightly higher in the surgical group, and we did include this in our weighted model. And then clinical follow-up, meaning any follow-up in the EPIC system, not necessarily specifically endocrine follow-up, was also a little higher in the surgical group. In our primary analysis, we found that adrenalectomy was associated with higher odds of improvement for A1C, BMI, and total cholesterol. When we did that complete case-only analysis, adrenalectomy remained associated with higher odds of improvement in A1C and total cholesterol, although our BMI findings were attenuated. And then in our time to event analysis, which included all patients with censoring at their last outcome measurement date, there were no differences across the outcomes. So in conclusion, adrenalectomy was associated with an increased likelihood of categorical improvement for A1C, total cholesterol, and BMI, although our BMI findings were attenuated in our complete case analysis. There was ultimately no differences in time to first improvement. Consistent with the existing literature, we also found variable responses across the different cardiometabolic domains. And this is a retrospective electronic health record-based study, so it does have residual biases or confounders that should be considered when interpreting the results. But all in all, our findings support individualized patient selection for adrenalectomy in the management of MACs. Thank you for your time. Happy to take any questions.
Great talk. Michael from Boston, no disclosures. Did you check for any interaction between BMI and cardiovascular health? And maybe what you're seeing is just as they lost more weight, that was driving the improvements versus treating the MACs?
Thank you for your question. We did not directly check for that, but I think that's an important point and would be a good marker for future studies with this database.
And all the way over here to the right.
Hi, Lena Hubianco, Dr. Srinivasan. Congratulations on this study. My question is, how were you able to distinguish DST cortisol from a random cortisol in your in the Cosmos database?
Yeah, we did it. Thank you for your question. We did it in two different ways. There are specific like lab codes that are directly coded as post-DST results. So that was one way. And then the second way was that we temporarily linked lab results to dexamethasone administration. So they had to get their dexamethasone at a specific time, and then the lab had to be checked within a specific time window afterwards.
Dr. Lee?
Yeah, Courtney Lee, Lexington, Kentucky. I have a question about, you may not have had the N to do this, but looking at the 1.8 to 5 versus 5 to 10, because 5 to 10, yeah, I'm pretty sure we're going to see that. It's that lower range that I'm kind of more curious about. So did you guys look at that or have any thoughts?
Yeah, thank you for your question. Unfortunately, we didn't have enough N in the two buckets to look at them individually, which is why we just controlled for overall cortisol level in our model.
Guido Mazzali at Providence, Rhode Island. I may have missed this in the very beginning, but how did you exclude Cushing's patients?
Thank you for your question. I might have forgotten to say it. We excluded by ICD codes. We did leave 2 in just for the possibility that people were being miscoded as max. And then that was why we set our upper boundary as 10 for our cortisol levels in the hopes that that might also exclude people with overt Cushing's, since it's difficult to find the phenotypic features in like a electronic health-based record like Cosmos.
And I mean, there was a time where Max was called subclinical Cushing's. How did you account for that?
Our hope was that I think it was 24.8 and E24.8 and E24.9 were the ICD codes that we left in. Primarily when looking at cortisol levels linked to that, they tended to be within the max range, which is why we left those 2 in to try and account for that historical aspect.
Just one quick question. Patricia Cronin, Mayo Clinic, Arizona. Were you able to account for any confounders like medications like GLP-1s that may also impact these risk factors and markers you were looking at?
Yeah, thank you for your question. We did account for GLP-1 use between the 2 cohorts, but we didn't account for other medication factors.
I have 2 questions for you. So the first is, you concluded that individualized patient management. What do you mean by that? Do you mean, because right now the recommendation is that anybody with MAC should be considered for surgery. Does your data suggest that we should focus on those with diabetes or those who have higher BMIs, or how do you put your findings into that context? And then my second question is, it looks like only about less than 20% of your cohort actually had surgery. And so are you doing something within the institution to try to increase that rate of surgical referral, or trying to outreach, or how exactly is that happening?
Yeah, awesome. Thank you for your questions. For your second one, for the Epic Cosmos database, it pools from many of the Epic-facing institutions across the country. I think it's possible that some of these patients that are diagnosed ultimately get surgery elsewhere, and it's just not being captured in this database. I do think the levels are a little low for that. And then I think it's hard to outreach to individual institutions through that database. And then for your first question, I think the important thing would be in counseling patients. Like you made the point, people are recommended for surgery, but I think being transparent that specific parameters might improve more than others would be the best way to use this data when counseling patients.
Thank you. Nice job.
Thank you.
Our next paper is the utility of cosentropin stimulation test in the assessment of adrenal function after unilateral adrenalectomy, presented by Dr. Dogukan Akis from, I think, a few different centers. So Cleveland Clinic, Washington University, and the Instituto Nacional de Ciencias Médicas Nutrition Salvador Zubrian. I'm sorry.
Hello.
Thank you.
Good afternoon. I am Doğukan Akkuş, research fellow at Cleveland Clinic. I would like to thank AAS for the opportunity to present our work today. Postoperative adrenal insufficiency is reported in 22% to 50% of patients after unilateral adrenalectomy performed for indications other than classic Cushing's syndrome. However, there is currently no consensus in the literature about the choice of biochemical testing and initiation of steroids. Our objective was to investigate the utility of cosintropin stimulation test in the assessment of adrenal function after unilateral adrenalectomy. This was an IRB-approved retrospective study of patients who underwent unilateral adrenalectomy between 2010 and 2026 at the Cleveland Clinic Endocrine Surgery Department. Patients were divided into max and non-cortical screening tumor groups based on preoperative hormonal testing. Patients with a history of preoperative steroid use and those who received intraoperative dexamethasone were not included in the study. On postoperative day 1, basal cortisol was obtained at 6 a.m., followed by cosintropin stimulation test. There were 179 patients in the max group. In this cohort, when postoperative day 1 a.m. cortisol was less than 5, 75% of the patients had an abnormal cosintropin stimulation test result. All of these patients were started on steroids. Although abnormal cosintropin stimulation test was normal in 25% of these patients, and most of these patients required steroids due to symptoms of adrenal insufficiency. Hence, we recommend starting steroids after unilateral adrenalectomy in all patients with MAX whose postoperative day 1 cortisol is less than 5 without doing a cosintropin stimulation test. In patients whose postoperative day 1 cortisol was greater than 10, cosintropin stimulation test was normal in all patients. Only 1% of these patients required steroids due to symptoms of adrenal insufficiency. As a result, in MAX patients with a postoperative day 1 cortisol greater than 10, we recommend omitting the cosintropin stimulation test and not starting steroids. In the intermediate group of patients with a postoperative day 1 cortisol between 5 and 10, cosintropin stimulation test was abnormal in 38%, and 74% of these patients were started on steroids. In 62%, cosintropin stimulation test was normal, and steroids were not started on 7% due to symptoms of adrenal insufficiency. At a median follow-up of 18 months, none of the study patients discharged home without steroids developed adrenal insufficiency. Hence, the most utility of cosintropin stimulation test after unilateral adrenalectomy for MAX seems to be in this intermediate category. Overall, 30% of patients with MAX in our study were started on steroids. In the non-cortical secreting tumor group of 119 patients, cosintropin stimulation test was normal in those with an AM cortisol greater than 10, and none of these patients required post-op steroids. In both low and intermediate post-operative day 1 cortisol subgroups, cosintropin stimulation test results were normal in most patients. However, cosintropin stimulation test was abnormal in 15%, and this helped identify those who needed to be discharged on steroids. Overall, 16% of patients in the non-cortisol secreting tumor group were discharged home on steroids. A machine learning model using preoperative data accurately predicted cosintropin stimulation test results. For instance, patients with a preoperative dexamethasone suppression test greater than 8.2 and tumor size greater than 25 millimeters had an 87 predicted risk of abnormal cosintropin stimulation test. In conclusion, based on our results, the most utility of cosintropin stimulation test seems to be in patients with intermediate postoperative day 1 cortisol levels between 5 and 10 in the MAX group, and in patients with low, less than 10 cortisol levels in the non-cortisol secreting tumor group. A routine postoperative day 1 morning serum cortisol determination, followed by selective cosintropin stimulation test, supplemented by clinical assessment, may enable a patient custom assessment of adrenal function after unilateral adrenalectomy and minimize the number of patients receiving unnecessary steroid replacement. Thank you.
Thank you for that presentation. While we're waiting for questions, in the non-max group, you said you had 16% that were started on cortisol replacement based on their cosintropin. How do you explain sort of the physiology for that?
Our team previously reported that patients with or without hypercortisolism are also at risk for postoperative hypercortisolism for unclear reasons. And recent studies shown that, I'm sorry. A recent studies show that preoperative hormonal testing may not able to identify patients who may not be able to identify, sorry.
Let me help out with that. So, we showed before that actually even if the patient don't have evidence of hypercortisolism, despite doing extensive testing, then we might still not be able to identify those secreting patients. It's been documented in the literature as well. And as a result, we're not really able to explain those, but the data suggests that you should also, be aware of this phenomenon and check their cortisol levels post-op.
Thank you. I think we have some down this way.
Hi, Lila Morris-Wiseman, Baltimore, Maryland, no disclosures. Thank you for this study, and I think this is very interesting. Maybe I missed, can you tell us how you defined MACS? And then also, can you tell us what the total percentage of patients with MACS who were sent home on steroids and whether that's consistent with prior data?
MACS was defined according to the guidelines with abnormal dexamethasone suppression test with adequate serum dexamethasone level and absence of overt signs and symptoms of Cushing's syndrome and absence of overt cortisol excess.
So what was your level for dexamethasone suppression test? Because you showed an average patient had a dex suppression test cortisol of 8.3. So I'm just wondering what your numbers were for your dexamethasone suppression test.
It's defined as 1.8 microgram per deciliters, but 8.2 is defined based on our machine learning models.
Let me make one more comment on that. So the patients had, obviously, these are all comers, so, some of them had. We use the current guidelines suggesting that 1.8 is your threshold, but obviously some of them, and these are a smaller percent of the patients had a higher DST cortisol levels. But what's important is that compared to the literature, like Dr. Tracy Wang's group and Dr. Banco's group reported that MACS patients, about 50-60% of the patients go home on steroids. It shows that if you use this algorithm, it goes down to 30%. And nobody in follow-up developed adrenal insufficiency at a median follow-up 18 months. That's our main message.
Okay, thank you. What's the max, the maximum level? So
maximum
greater
level,
than 1.8 to what?
Maybe I don't know. I think some patients maybe 10 or 12.
But isn't that overt hypercortisolism?
No, if you look at the data, the definition of max in the European guidelines or others, you use 1.8, and these patients do not have overt signs of clinical Cushing's.
Okay, thank you.
Thank you. We have another question here.
Yeah, Sean Johnson from Vanderbilt. Question about the STIM test. What you define as abnormal, so some people would call a baseline non-stimulated cortisol less than 5 is already an abnormal STIM test. And then also about whether your STIM test results correlated with things like how long patients were on steroids afterwards. So is an abnormal STIM test, is it something we should consider to be a binary result that it's abnormal or normal, or can we actually use that number to look at things like how long we expect a person to be on steroids for? And that's including things like your post-op day 1 ACTH plus your basal cortisol plus your 30-minute or 60-minute, whatever you're doing.
Okay, for the sake of the time, let me take that question as well. So basically, the scope of this study is not really how MACS should be decided. We just went to the most recent guidelines, and they said, very clearly 1.8. Yes, I agree. You can actually also categorize MACS based on a lot of variables, including dexamethasone suppression test result. We also did not do actually a correlation here about how long the patient had to stay on steroids based on their preoperative dexamethasone suppression test results. I think these are some potential ideas for future studies.
Great, thank you. And I think we have time for one more.
Talia Bernakis. I'm Talia Bernakis. I'm in Oklahoma City. Nicely presented. I just had a question about very specifically in your intermediate group, who underwent the dexamethasone suppression test and had an abnormal result, you only sent 74% of them home on steroids. And my question is, are you using that like strictly, or what about that specific patient population allowed you to avoid steroids in them? And then sort of a secondary question, do you have any sense of who presented with adrenal insufficiency complications, either short-term when you didn't send them on steroids? Thank you.
We didn't see any adrenal insufficiency complications after we discharged from without steroids. And for the first question, you mean the non-max group or max group for intermediate group?
The max group, I'm pretty sure you said only 74% with the abnormal went home on steroids. So the point being, is the algorithm strictly guiding your practice, or what other clinical factors are you taking into consideration to avoid steroids in that patient population?
In case of discordance, we evaluate the patients with their symptoms and possible suspicions of adrenal insufficiency. If we think the patient will have adrenal insufficiency, we started steroids, if it's normal or not.
And also, Talia, this algorithm has been evolving over time. We just used to just look at post-op-day one cortisol. And then those kind of the variations in the percentage are related to the fact that the patients have some borderline values. Like if your post-op-day one cortisol is like 7, it's less than 10, and you stimulate maybe up to 11, you don't have symptoms. It's not actually those patients, we have repeated their cortisol the following day, and most of them it comes back to normal. So this is an algorithm evaluating kind of evolution, and I think that, but these are kind of the main kind of the principles.
All right, thank you. I think we're just done for time, though.